Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new TEAM therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Hello, David. And welcome, listeners, to episode 263. We have a really special guest today, Taylor Chesney, who's the director of the Feeling Good Institute in New York. I know David wants to say something about Taylor, too, as we introduce her.
Taylor who? Taylor is a brilliant and beloved colleague. Spent at least 2 years in the Tuesday group at Stanford after completing your doctoral degree in clinical psychology, and went on many Sunday hikes. So we've shared a lot of times together. We've done personal work together, and one of my favorite people in the world. And then Taylor and her husband, Gregg, who's an emergency room and intensive care unit doctor in New York, moved home to New York. And Taylor, you started the Feeling Good Therapy Center in New York City. And so we've missed you a lot. We're grateful for the time we did have together, and it's always fun to reconnect. Some of you may remember that part of our training is doing personal work, so you have the experience with TEAM, and both Taylor and Rhonda, as you know, have done personal work that was featured on previous podcasts that were appreciated by many, many people. And so welcome back, Taylor, today, Taylor, great to see you. Absolutely fantastic. And you're going to bring us a really neat topic, one that I don't think is talked about very often, and one that has probably a fairly simple and straightforward solution most of the time, if people are willing to implement it. So Taylor Chesney, Dr. Taylor Chesney, will inform us in just a moment on how to treat children and adolescents with obsessive-compulsive disorder using TEAM plus common sense. But first, Rhonda may have a few niceties to share.
I do. I have two really great things to share. And I would remind our listeners that Taylor was on our podcast in September of 2020 when we titled that one Corona Cast. That was the fourth in a series of podcasts we did on how this epidemic is affecting us. And Taylor was talking about her concerns about how she might lose her husband, who's an ER doctor, and that we got we were talking before we started about how many warm responses Taylor and we got about that podcast.
Yeah, and that was a great one. And also, there isn't any conventional treatment for anxiety or depression during the corona or any other epidemic or trauma that people have. It's always due to our own individual thoughts. And by the way, that meow was our little kitty who might come in and join us, so you can see her shaking some cat can. Sweetie pie, come on, sweetheart. We adopted her from the Humane Society. She's 6 years old, and she's the sweetest cat we've ever had. Mm. But where was I?
Well, speaking of sweetness, let me read these two great endorsements. Well, one was regarding episode 244, and that was on the paradoxical nature of TEAM, featuring Matt May, and we published that on May 31st of 2021. And this was Rob who is a team therapist, and he wrote, "I can't tell you enough what an awesome learning tool these podcasts are for understanding TEAM. It's part of my homework assignments for Learning TEAM, but I also assign them as introduction and as homework for people I'm helping with TEAM. They're a great resource and very fun to listen to as well. So thank you again, Rob."
Well, thank you, Rob, and I certainly endorse what he says. And by the way, I've had a lot of endorsements for you, Rhonda, which I pass some of them on, but not all of them. But in general, people saying how fantastic your contributions to the podcast are, the joyful spirit and the fun spirit that you set. And that's so much a part of TEAM, too. The idea, and a lot of people beat me up for saying this, but the purpose of TEAM is to make your depression and anxiety disappear so you can have fun and joy in life. And we all suffer at times, or most of us anyway. There are bumps in the road. And it's great to have tools so you can turn that around and get back to a sense of joy. And you certainly project that and live that, Rhonda.
Oh my gosh. Well, thank you so much. I really appreciate that. Well, no, I'm kind of I don't know what to say. Well, let me just read one more endorsement, and then I want to get into Taylor, because all those kind things that you said about me, we could also say about Taylor, who's going to bring a lot of joy and spark to this podcast. So, as many listeners know, Dr. Burns has 2 free chapters on his website that anyone can download. One is on ending habits and addictions, and the other one is on how to make difficult decisions.
And which is also slanted on how to make difficult decisions, because the decision to give up a habit or addiction is always a difficult one, and that's just a tool that can help. So there are really 2 chapters on habits and addictions, and if you want them, they're on the bottom of my homepage, because people say, I can't find them on your homepage. Well, they're about as huge as half of your screen on the bottom of the homepage. Click here for the free chapter. It just says 1 free chapter. But if you click there, you'll get 2 rather than 1 free chapters. And they were supposed to be in the new book, Feeling Great, but they're not, because the book was too long. So this is the only place you can get them. And they have fabulous new innovative techniques. And with that, you can read your thing.
Okay, well, this was written to you from Ron, who's a clinical and school psychologist. And he said, "Hi, Dr. Burns. Thank you so much for the chapter on habit and addictions. It is brilliant, and I'm utilizing its principles right away. I bought your book, Feeling Great, last week and poured through it excitedly. And may I suggest humbly that it is probably your magnum opus. Although I must admit, I can't be sure, not having read every single thing you've ever written, but I've already incorporated it into my practice and into my life, as well as my children's lives. I bought 5 more copies, 1 for my wife and 1 for each of my 4 children. Thank you for that. Sincerely, Ron."
Well, thank you so much, Ron. I'm just blown away by your kind comment and appreciate that. And for any listeners who might want to grab a copy of Feeling Great, it's ridiculously cheap right now on Amazon. They have it discounted to where it's almost pretty much the same price as a trade paperback version of one of my earlier books, The Feeling Good Handbook. And so if you're interested in getting a copy, this is a great time to do it. In fact, and this is weird, they've priced it so cheap, they won't allow the publisher to advertise it on Amazon right now for some reason. And I think it's trying to discourage book sales because they lose money every time they sell it. They're selling it so cheap. But at any rate, check it out if you're interested. And thanks, Ron.
Well, Taylor,
now,
back
go
to
ahead.
Taylor. Taylor, tell us how you got interested in the topic of treating children with obsessive-compulsive disorder, and just tell us also a little bit about your practice and what you're doing in New York. And I wonder if listeners are interested in hearing about how Gregg is doing too.
Sure, lots of great questions. So good to see you, David and Rhonda. Thanks for having me back on the podcast. I always love joining you. I'm the director of the Feeling Good Institute in New York City, and so excited to be here to talk on the topic of how to best utilize team therapy to help parents and children and adolescents suffering with OCD. And the reason I want to talk about this is because throughout the pandemic, I've just seen such a rise in OCD symptoms in patients throughout the pandemic. And I kind of got curious, trying to think and hypothesize why. I probably don't know exactly why, but have lots of interesting theories. And so I just thought it would be important and helpful for people to kind of talk a little bit about how to think about the treatment of OCD. And there's so many wonderful OCD resources out there for methods. So I wanted to more focus rather not on how to treat it, but how to set up for successful treatment, because I think that's how TEAM really helps in this treatment.
Great. Now, we try to keep our podcasts at the 4th to 5th grade level as much as possible. And many of our viewers won't know what we're talking about already. What's OCD,
Right.
type of thing. That's obsessive-compulsive disorder. But why don't you turn us on to what it is? What are the symptoms, especially in children? What are the obsessions? What are the compulsions? What are we talking about?
That's a great question. I hate to talk jargon that no one could understand. So OCD, as David said, is obsessive compulsive disorder, which basically means that there's some sort of pattern of unwanted and intrusive thoughts or fears or images, sensations, anything that someone is experiencing as unwanted that leads to a feeling of distress that is bothersome to someone. And so that could include anxiety, things feeling just not right, uncomfortable. And then to make those feelings go away, the child or adolescent engages in repetitive behaviors aimed at decreasing that discomfort, because no one wants to experience discomfort. And what I'll add above and beyond that for parents also, how it's different than adults that have obsessive compulsive disorder, is parents also sometimes engage in those behaviors to take away the distress or suffering of their children, because no one wants to see their children suffering. And so these unwanted thoughts are called obsessions. That's how we have the obsessional part of the title. And then the compulsions are the unwanted and often repetitive behaviors that try to decrease the discomfort that they're experiencing.
Give us 2 or 3 specific examples so we'll know, because we're still at the kind of the 8th or 12th grade level. Absolutely. And so, like, what are these these thoughts and fears and images that upset the child? And then what are examples of repetitious behaviors that the child might engage in to try to avoid the images? So what are the obsessions, the thoughts, and the compulsions, which are the rituals?
Right. So in popular movies, probably what most people understand as OCD is like obsessive hand washing, right? Like fear that you're going to get sick or that you're dirty, and then you will contaminate something. With children, it may be fear that a loved one will not come home or get hurt. So now we see that as like kids compulsively texting their parents, "Are you okay? Where are you? When will you come back?" Another obsession is just wanting things to be a certain way and very orderly. So a child may organize all their pencils in their room a certain way. They may line up their notebooks a certain way. It may be a ritual before a sports match. So there's a lot of different ways, and it could be very confusing for parents to know, are these normal developmental rituals or is it OCD, right? So we really have to look at the distress or the upset that it's causing, right? So an obsession or a desire to have shorts before camp be just the right way, maybe like the child fixing their shorts, right? But we see a compulsion is like a repetitive behavior that they really just feel like they can't stop.
Now, on TV, we see a lot of these compulsive rituals, particularly in sports. Like you'll see baseball players, before they get up to bat, they'll open and close their gloves on both sides, and others do various rituals. I can't think of what they are right at the moment, but there is a kind of a lot of that superstitious things that you do, and I suppose they're thinking this will improve their chance to get a hit or to perform well. Did you also say that the contamination that's typically more with adults, and that the fear of a loved one will get hurt or won't come home, and then wanting things to be a certain way, highly organized on the desk, line up the pencils just right. Those kinds of things are more typical of children. Is that correct?
Yeah, absolutely. Another one that I've seen a lot in children is fear of getting sick, or they've had a stomach virus. So then they obsessively check expiration dates on the milk, on food, and they need reassurance from their parents that the food hasn't been out long enough. So I think all of these can be seen in both children and adults, but just in slightly different ways.
Right. Now, I know you're going to be going in a different direction with the treatment, but you are very aware of this hidden emotion model that I've developed among other ways of treating anxiety. One of 4 treatment models or methods that can be helpful. And so what jumps to my mind right away, if a child has a fear that a parent won't come home or is going to be hurt, would there sometimes be, and this would be kind of a psychodynamic or psychoanalytic interpretation, which is actually sometimes of great practical value and absolutely correct, that this is an overly nice child who is not allowed to be angry, or so they think, or to have any negative feelings, and they might be angry with the parent or kind of have a secret desire to hurt the parent, and they kind of deny and suppress that, and so it comes out as all these fantasies of the parent never coming home or being hurt.
Absolutely. And I don't know that I would say I would take this in an entirely different direction, David. I think that's a really important part of what informs my treatment. And that's why it's so much more complex with children, right? Because that child might have a hidden emotion. And so in order to best treat OCD in this population, it's really important to also have an alliance with the parents and to be able to talk about these things with parents and also educate parents on how to improve their communication using the 5 secrets with their children.
Oh, I see.
Have a language to talk about that anger or frustration, because you're absolutely right that a lot of the symptoms do develop out of children feeling like they can't express their, I'll say generally free will, right? Like their ability to be angry, to do the things they want to do. So, well, not to get too psychodynamic, right? But they seek to control what they can't control. And so the hidden emotion is very relevant.
Oh, cool.
Yeah,
that's a new twist that I've never used with adults. Is, with adults, I'm always trying to get them to express their feelings. But the idea that you can bring in the parents as co-therapists to urge the children to open up and share those feelings, I've never thought of that before. Yeah. And that is really, that is really cool. And I'm always looking in programs for tips for listeners, whether they're therapists or the general public. And if you are a general public and you have, a child with any form of anxiety, actually, not just OCD, that you probably have an overly nice child, and sitting down and encouraging your child to open up and make it safe for them to express anger and desires, without feeling put down or criticized or censored or something like that, could be one of quite a number of things you can do that's potentially helpful.
I think that was the most specific and clear definition of obsessive compulsive disorder that I've ever heard. I really appreciate that. So that's such a good teaching. And I love all the descriptions of how it's different with children than it is with adults. The fear of their parent not coming home. I wonder if that's, you said you noticed more obsessive compulsive disorder patients being referred to you during the COVID crisis. And I wonder how you think that's connected.
It's a great question. And yeah, I think there's a lot of fear and uncertainty in this time, right? And obsessive compulsive disorder is a disease of difficulty tolerating uncertainty, right? And so at a time where children, adolescents, adults, worlds were turned on their head with a day's notice, right? Like a lot of the schools were open one day, then they were taking temperatures of the kids the next day, and then all the kids were sent home, or some version of that last year. And then this year, having to go with masks and temperature checks and lockdowns and just so much change. I think children are really wanting routine and ritual and certainty in a time where they don't have it. And they're feeling frustrated as a result of that. And I see that in my children. I see that in the children and adolescents I treat. And I think they're just really needing a lot of love and empathy at this point, like we all are. And so I think at difficult times like this, they're really searching for certainty. And so I think that's my hypothesis of why. And we'll never exactly know why, but I feel excited to know that there's ways to help and support, right? Regardless of how we got to the symptoms developing.
Well, I love what you're saying. And we had a podcast. We did a survey of several hundred of the listeners and asked them how they were feeling in 5 or 6 different dimensions before the COVID began, and then how they're feeling now. And we saw, especially in women, 100% increase in every negative emotion, like depression, anxiety, anger, hopelessness, things like that. And in men, we saw a doubling of anger. And then other people have done similar polls and confirmed a similar increase in negative emotions. And my point is that anxiety, I think, is kind of an infectious emotion. That if one person is anxious, the other people in the room might start getting anxious as well. And so children would certainly be picking up from parents the anxiety that almost everybody was feeling, and it is feeling now with the new Delta variant. The anxieties, I'm sure, charging up again, and we see people dying on TV all the time, and also the anxiety about all the intense political conflict in the world. And so the child becomes anxious. And so then if the child has a tendency toward OCD, that their OCD is going to get fired up. And by the way, I think we all have to do our duty now, and then I'll shut up again and get on to what Taylor really wants to say. But they've asked people with some social following to start helping promote the vaccinations. And there are thousands of podcasts and people with some social following. And since we have some, Rhonda, I just want to encourage all of our listeners, wherever you are in the world, to go ahead and get vaccinated and protect yourself and protect the rest of us as well. We understand your concerns that some of you may have about not trusting the vaccinations. I've been doubly vaccinated. I had very few or no side effects. I'm going to certainly get a third booster shot as soon as I can. And we all need to pull together as a country and as a world to defeat this thing, because it's mutating rapidly. And the war with COVID is not over. And it's mutating and getting more and more contagious, and it's just a matter of time until it mutates into more virulent and more deadly, although the current form is pretty darn deadly. And the one way we can beat it together is to put politics aside and listen to science and get vaccinations and do yourself a tremendous favor. So back to you, Taylor.
Thanks, David.
So Taylor, can you walk us through, like, you get a phone call from a parent who's concerned about their children or their child, and they're coming to you for therapy. How can you walk us through how you treat that child and how you incorporate the TEAM model?
Sure, absolutely. It's a tall order, but I'll point out sort of what I feel are important points. And before I jump into that, I just want to say a lot of times, very rarely do I get a referral that says, like, my child has OCD, right? A lot of times it's anxiety or depression. And through the symptom measures that I do at testing before treatment starts, we kind of realize that that's one of the things that are operating. So when I work with a family, I start, depending on the child's age, I start with an intake with the parents, and then I do 2 sessions with the child. And in the parent session, I'm trying to connect with the parents. I find that they have to feel like I understand them, their family, their life. And for me, it's always most important, even if the parents have a parenting deficiency, or is to view them as doing the best job that they're able to do, and how to empathize and form an alliance with them so that I can either best help them help their child, or help their family or their child, or give them some feedback that can be helpful. And then I do a intake with the child. First and foremost, the first session is just connecting with the child and adolescent. It's just so important to kind of get to know them, their hobbies, their interests, what they think about their family, where they're living, the pandemic, all of those things, really connecting with them and empathizing with them using the 5 secrets, and learning also what their take on it is. Because in this third session, or the second session with the child, I'm going to get a sense of how they're functioning and what symptoms they're experiencing, and which of those they see as a problem for them, right? Because when I do the intake with the parents, I want to get a sense from the parents of what they think the problem is with their child, what they're struggling with. But I also need to, before I jump into the treatment, get a sense of who sees it as a problem and who is willing to do the work, right? I have lots of tools and techniques and resources, but unless we're all aligned in how we see the problem, it's going to be challenging to help. So in that the 4th intake session is where I'll present kind of the parent's view on the situation, the child's view, my view, and then I'll present to them some treatment options. And I can only move forward with a family at that point if we're aligned with what we're working on. If the child doesn't see the symptoms as a problem, but the parents do, I'll let the parents know that, and I'll work with the parents. And if it's the child, then I'll work with the child if they're asking for help on the things that I feel like I can help them with. And then in an ideal situation, we all see it the same, and I can help the parent and the child both at the same time.
So let me just repeat what you just said. If the child doesn't see it as a problem, but the parents do, then you'd work with the parents, and so the child might be having some ritual of adjusting things on the desk or whatever, but doesn't want to work on changing that. Right. But if the parents are concerned, then work with the parents, and you'll tell us kind of how that works. And I love that, because you can't help anyone, including a child, against their will, unless you have a very firm intervention from both parents. Now, if the child sees it as a problem, would the parents always see it as a problem, or might they not?
I think in general, if the child is seeing it as a problem, in my experience, most of the time, the parents are on board. The situation where they might not be on board is if a child presents, let's say, with anxiety, social issues, and procrastination, for example, right? And the parents want you to help them with all, and the child says to me, I'm really socially anxious and shy, and that's what I want help with. The child might want help with that. And the parents might see, for example, the procrastination as more of an issue, and the parents' agenda may be the procrastination. So there's definitely situations where they both are aligned, but also I try to be very specific on what I'm helping with, and the parents may have a different agenda in that sense in the child.
Well, what would you do then? The child wants help with social anxiety, and the parents want you to help the child with procrastination.
Mm-hmm. In that situation, in the wrap-up session, I would have a discussion with the family on this and let them know that the child's wishes are for help with social anxiety. And I'd feel really excited if everyone was willing to allow me to work with them on that. And I would help the child with that. And I would let the child know that it sounds like procrastination doesn't feel like an issue for you, and that's not something you're interested in. At the same time, your parents are very concerned about your procrastination and the impact on your academics and your functioning. So they've asked my help with that. And I would say to them, my preference would be to help you if you wanted help, because then you would be in the driver's seat, right? But if you don't want that, I totally get that. And I'll help your parents figure out how to get on the same page around, I wouldn't necessarily tell the children my treatment plan for them, but I would let them know that your parents are asking for help with that. Because I find in the treatment of children, adolescents, secrets often sabotage treatment. So I would never want to help a child with social anxiety and secretly be helping their parents with procrastination. I would get their consent ahead of time and be transparent with that.
Yeah, I absolutely love what you're saying. It makes so much sense. And I think back on places we might have talked about things like this on trails. Mm-hmm. Like going up from the reverse trail where we'd start at the that area off of 280, and then we'd hike back to my house up over the hill. And I remember a certain curve there. We were discussing one of your patients at that time and talking about the whole issue of agenda setting, and it's the key, what you're saying, to treatment with adults and children, because 100% almost of therapeutic failure results from not working with a meaningful agenda with your patient, or in your case, with the family. And that's where the magic is, in the setup. And if you kind of ignore these issues or naive about them, or don't know how to deal with them, then you can be kind of flailing around, throwing techniques at people, or just having them come and talk, and neither strategy actually moving forward to change somebody's life. And I would say one of the pieces of TEAM, which a lot of therapists get hostile about and don't want to hear, is that we're here to change somebody's life, and to do it as quickly as possible, and to do it in a way that can be measurable and proven that you're having an impact, that the anxiety is actually going down, the social skills are getting better, the OCD is being tamed, that lion is being tamed in a real and measurable way. And without this, people working together as a team, it's not very possible, and usually impossible to make meaningful change.
And I imagine the children and adolescent patients that you work with, Taylor, must feel so respected and happy to be working with someone that is working from their perspective and what their choice is.
I sure hope so, because I love working with them, and it's such a joy to see them make the changes that they want to make. It's
Mm-hmm.
also frustrating at times, right, when a family is not aligned, but I feel so grateful to TEAM. There's a family that comes to mind where they really wanted me to help their child with OCD, and the child didn't want the help, and the parents weren't willing to do the work. They just weren't able to at that point. And there's great resources out there. I can be helpful. There are programs that are geared towards just helping the parents if the child doesn't want help, but I have a great relationship with them, and they feel empathized and understood, but they're just not ready to deal with the symptoms right now. And I feel like TEAM and sitting with open hands has just given me so much confidence to say, like, I have the tools to help, and I hear you that you're not ready now. And when you are, I'm here for you.
Mm. So let's say you're now at a place where the parents and the child or the adolescent are all on the same page as you. What are the next steps?
So that means testing has happened, really good empathy, that they feel really understood. I always circle back to agenda setting, right? Even if they've said yes, right? Like, yes, I want help. I think it's really important with OCD for them to also understand sometimes what their symptoms say about them. That's really positive, and how it kind of reflects their values, right? A child that worries about their parents and wants to guarantee their safety and goes through rituals to kind of make sure their parents are safe or checking in. That's such a wonderful thing about them, right? They love their parents so much. They value their family and they want to kind of keep them safe, and they go through these rituals, right? So I think in some sense, it's important for children to realize that these aren't horrible, terrible, bad things, right? That they actually kind of reflect what's good and right about them. You know, just like we think of anxiety, right? Performance anxiety. You know, I have a lot of high school athletes that I work with, and they develop rituals around sleep and their sports and schoolwork. And a lot of it comes down to they just really want to do a really good job, and they're trying to figure out how to do that. So a lot of times when...
Can I just stop you here for a second here? So what you're saying is that, like, when we're working with adults with TEAM, we show that the depression or anxiety or anger, hopelessness or whatever, these so-called symptoms of a mental disorder are actually expressions of the core values of that person and what's most awesome about them as a human being, and that these so-called symptoms of illnesses are actually have benefits to the person and can be quite appropriate for their current situation. And what you're saying, it's the same with children, like a child with like OCD, and they're in athletics and they're getting ritualistic about their eating and their exercise. That's actually a reflection of their core values of wanting to be a top athlete and wanting to do a great job. Now, why would that be an important part of the treatment, Taylor?
I think it would be an important part of the treatment for so many reasons, right? But a lot of people think, oh, I'm going to get treatment, now those things are going to go away, right? And we want them to realize that they can be free of the symptoms while still maintaining those values, right? That you can kind of turn down the intensity of that fear, or that you could kind of hold on to that without this learned behavior, right? And a lot of the treatment of OCD, obviously exposure with response prevention, which we'll talk about, is kind of like the gold standard treatment. But I find that for children and adolescents, so much change happens in the psychoeducation, which is just a fancy word, right, for kind of teaching them about the disease. And I find that the more children feel empowered and understand it, obviously they need more than just understanding, but when they really get the disease, it does help a lot with the treatment. So I do find that really understanding what values it reflects really helps them, you know, honor those symptoms as opposed to pathologizing it.
Lovely. That's terrific. I really resonate with what you're saying, and I think it's helpful for all patients that we're kind of turning things upside down. That you come with suffering thinking you're broken, been told by society there's something wrong with you, and what we're going to show you is there's actually many things, tons of things that are right with you, and that your symptoms are an expression of your core values and what's most beautiful about you. And maybe it's not a matter of making this illness go away, so you're not broken anymore. The fact is you're not broken in the first place, but maybe just to turn down the intensity of these symptoms a bit, so you can maintain all these core values. And that's such a liberating maneuver, you might say, for a lot of different reasons.
Absolutely.
Okay, so then what do we do then once they've agreed to turn down the intensity of the anxiety and perhaps the rituals and whatever? What are the next steps?
Yeah.
And how do you engage the parents as to be a part of your team to help the child?
Right. So many wonderful questions, right? And it's a very complex treatment. So I'll share the most that I can about this, right? So the parents are a huge part in treating OCD, right? I always like to tell parents OCD is a family affair, right? If the child has completely successful treatment, but the parents don't learn anything about it, it's gonna perpetuate, right? It lives in the house, and we're dancing every day with the OCD, and it can be really scary for parents to think about not engaging in the rituals, right? So part of it starts with me explaining to the child and parent sort of what happens with OCD, right? And we have like an alarm system, right? I always like to think about, most people in psychology classes learn about the fight or flight response, right? Where our ancestors were walking around, hunters, gatherers, right? And it was very adaptive that when they saw an animal, their body prepared to fight it, right? And so when our ancestors saw a huge animal, I'm not so up with the brain chemistry and all of that, but right, a reaction happens. I'm sure, David, from your medical school days, you could speak to that more, but right, there's a reaction in our body that tells our body to fight off these animals, right? And
or to run and get the hell out of there.
Right, either fight or flight, right? Fight it or run away from it. And then when we get to safety, it sort of tells your body, good job, that was the right reaction, you're safe now. Right. And that reaction was very adaptive. And so anxiety is just a remnant of that, right? And our body, when we have OCD, it sort of takes over that alarm system. We continuously are scanning the environment and seeing animals and things that should be feared, right? So it's good when that system comes off and we're in a dark alley or being chased by a robber or something, right? When there's a real danger and it warns us and we stay safe. But with OCD or anxiety, that alarm system is just going off all the time, right? And our body is trying to protect us, right? So I fear that I'm going to get contaminated. I see like my hands are dirty. That must be an animal. And so I run to wash my hands and then I'm safe, right? So it tells my body like, good job. That was the right reaction. Keep doing that. But really, the child doesn't realize that if they didn't go wash their hands, they would also be safe, right? So it's sort of like a false alarm is a lot of times how I explain OCD, right? It conveys danger. Pay attention, you might be in danger, right? When they're not actually in danger. And so through exposure and response prevention, there's new learning that occurs. And what this is a fancy word for really is you learn something new, right? So you get dirt on your hands and you don't have the response that you normally have, which is washing your hands. And you have new learning that happens. You see that you're not in danger, or that you can tolerate and be more okay with the distress, right? So it's not always about feeling cool as a cucumber when you do it, right? But getting more comfortable with the discomfort.
Now, earlier you said that children don't get contamination, adults do, but now you seem to be saying that is something you see in children.
Oh, I think I misspoke earlier. What I was saying is typically what we like think of as OCD as is in the movies, right? Like contamination, OCD, sure. Kind of hand washing. But I wouldn't say by any means that that's the most common one that I see in children, but
it does exist.
It does for sure exist, and I think it's exacerbated.
Now, what should the parents be doing? And again, for our listeners, exposure means that instead of running away from the thing you fear, and the example you gave would be thinking that your hands are contaminated, so you've got to go wash them. Mm-hmm. So the exposure would be allowing your hands to get contaminated, and then the response prevention is not doing the compulsion, which is to go wash them. And the new learning that you're referring to is, although this will freak you out at first, it's like withdrawal from a drug. Mm-hmm. The drug being getting the relief by doing your ritual, washing your hands, and then feeling temporarily relieved. You're prevented from washing your hands, and then you discover that terrible things don't happen, and that you are safe. And this is the way you defeat the OCD, at the very least, the compulsion part. Now, where do the parents come in? Would they sometimes disagree? Is that what you're saying? And think that it's okay, and buying into the child's delusion and thinking, well, let's let Johnny wash his hands now because he touched the cat or some such thing?
Exactly, David. OCD is really hard for parents, right? A lot of parents have accommodated, which means given into the child's obsessions, right? And allowed them to continue to grow. Perfectly well-meaning parents. It's a very difficult disease to tolerate. And it's so sad to see your children suffer that parents often give into the rituals, right? The obsessions, and allow the compulsions to go on, right? So a parent's role is education on their role and pulling back, right? Not enabling the OCD to continue to grow.
Now, one thing that I've always taught in working with adults with OCD is that the compulsions are easy to treat, and the obsessions take more tools, like the response prevention is pretty much all you need with an adult, and probably with a child as well. Just to say to my adults, if you'd like my treatment, you're going to have to stop washing your hands, and you're going to freak out for a few days, and then that urge to wash your hands will diminish and likely disappear. And if you're willing to do that, I'm willing to treat you. If you're not willing to do that, I'm not willing to treat you. It's just kind of a black and white, a gentle ultimatum. I wouldn't know how to help you without this. But the obsessions won't necessarily disappear at that point. Unfortunately, we have dozens of techniques to treat the obsessions. So I guess a first step would be getting the parents to work as a team to lay down the law, or I don't know how you think about it, to tell the child, we're not going to allow you to keep doing this ritual anymore. And the child might throw a temper tantrum and freak out and really test the parents. But if the parents stay true to that, then the child's ritualistic behavior will diminish and disappear fairly rapidly. Now, am I on the right track here or not?
I think you're absolutely on the right track. The only thing I would add is, with children and adolescents, sometimes it's a little more complicated in the sense that we want to make sure it's a developmentally appropriate thing that we're asking them to do, right? And also knowing that the parents aren't always around, right? So how do the symptoms manifest at home? How do they manifest at school? How do they manifest with friends? And taking a system-wide approach and really understanding how the symptoms present, right? I have a lot of patients whose symptoms present across all settings, only some settings. And so the agenda setting, I think, is most important, that you're on a team against the OCD and figuring out for a child what is a reasonable step, right? And so I do find, in an ideal world, yes, it would be exactly as you said, kind of, you don't do the compulsion and it's gone. But we also want to be sensitive to, is the child needing to function in other ways too? And like, for example, if the child still wants to go on a sleepover, right, they may engage in some of the the compulsions at the sleepover, right? But if they could kind of get through it and it's not causing problems. So I think it's with children and adolescents kind of seeing a bigger picture than just the symptoms.
I could also imagine if a child is going through that exposure process with you, like, and they're freaking out, and they just continuing the example of washing hands, and they really want to wash their hands, and the parents, they're on board when they're in their office, but now they're at home and they're seeing their child suffer, and it must be just hand-wringing for the parents to see their child suffer, and how easy it would be to give in and say, okay, go ahead and wash your hands. And I'm wondering if that reinforces then the symptoms are really dangerous, and how do you, and reinforces the behavior and keeps it going. How do you handle something like that?
I think that's why the parent work is so important, right? Because parents don't want their children to suffer, right? And that reflects all that's good and wonderful about them, but that's counterindicated in the treatment of OCD. And I think the problem with OCD and how it's so tricky is a lot of times parents come to my practice and don't even know that the dance that they're engaging in with their child is OCD, right? Because rituals, right? We talk about baseball players or athletes, right? Some rituals are really important, and routines and predictability with children is really important. So a lot of times OCD does develop out of normal childhood rituals and routines. And so sometimes it's been there for a long time and the parents are feeding it. And so it's really challenging in that way to know, is this a normal childhood ritual and routine? And does it help them give them order, right? Like a bedtime routine. If you speak to any child development specialist, I'm sure you both know with your children, right? Like a routine around bedtime, a routine in the morning helps them get set up for school. So we do, as parents, put a strong emphasis on ritual and routine, and those are adaptive. And even some child behaviors that they make up their routines and rituals on their own, not to embarrass my son, right? But like he had like a saying and a ritual that he had to do every night from the time he was 2 years old to 4 years old before bed. And I was like, oh my God, am I feeding his OCD, right? But it felt like once I said it enough times, he was able to kind of go to bed. And now that's totally not a thing, right? So as parents, I have a lot of empathy for them because it's really hard to know, is this a routine and a ritual, right? Like before my kids leave in the morning, I give them a hug and a kiss, right? That's a ritual, right? They wouldn't like to leave without it, but it's not impacting their functioning. Mm-hmm. And so I think this was a long-winded answer to someone's question, right? But the idea is that with children and adolescents, these symptoms are also an adaptive part of development. So it's asking and knowing how is it impacting their functioning is important to understand.
So is there a lot of psychoeducation with the parents on how to manage their own anxiety and distress when they see their children suffering?
Absolutely. That's something I really wanted to talk about too, is a lot of times parents have their own mental health issues and their own anxieties. And I think 100% not to blame parents, but I think one of the reasons that there's also an increase in OCD during the pandemic is we're all more stressed and anxious. We're all at home more, right? So one of the things that I do with parents is also work on their own negative thoughts using a daily mood log to help them work through their own anxieties, whether it's should statements like, I shouldn't let my child suffer, right? So that would lead them to engage in the rituals and reassurance if they're thinking like a good parent doesn't let their child suffer, or I should have known better, or I can't handle this, right? So really figuring out what are the thoughts that the parents are having that may sabotage treatment or that may help them be better versions of themselves to help their children better.
I love what you're saying. It's so nice and clear and lucid. And I think that's what our listeners like, is to have things, and what I like personally is having things explained in simple terms that even I can understand. Because so many times people are involved in jargon and it frustrates me because I don't know what the heck they're talking about. I went to a workshop once with this very famous psychoanalyst, And I can tell you, he was just babbling psychosis all day long. I mean, it just made no sense. And he's one of the most famous psychoanalysts in the United States. And everyone just thought he was wonderful. And I thought, I had no idea what the guy was talking about. I'm pretty sure you didn't either. But I love the clarity now. There's an interesting analogy because most therapists in the United States refuse to use exposure and response prevention, thinking that their patients can't tolerate it. And so they deprive their patients of exposure, which is it's not the only tool in the treatment of anxiety, but it's a mandatory, and it's the most proven effective treatment on the surface of the earth. And yet most therapists just want to keep talking endlessly to their patients. And of course, the patients don't want to use exposure either. So they're kind of like reinforcing each other. And if it's a full fee patient, the therapist doesn't mind. Just you like the person, you talk forever, and you get a nice weekly income. But it's the same with the parents, that you have the job of trying to persuade the parents to use exposure and response prevention with their own children so their children can recover. And you say that, not surprisingly, that many of the parents resist that, and they want to keep giving in to the child and coddling the child and allowing the child to do these various rituals, which gives the temporary relief. But in the long term meaning like 10 or 20 minutes, it would be the long term, things get worse because the child gets more and more addicted to this ritual. And then you also said that it's a little hard too, because like all symptoms, rituals are just an expression, a manifestation of something good. Having rituals in our life, having order, having rules, having patterns of doing things so we can keep on top of things. And so it's sometimes hard for parents to know where's the drawing line between, healthy organization. I mean, I could certainly straighten up my desk a bit, versus getting all compulsively involved in a perfectionistic way of OCD.
Taylor, I love how you work with the parents and support them. And I think that's so critically important to the health and the success of the treatment. But it sounds like a lot of balls to juggle in your treatment with the children. Do you ever refer the parents to another person in your practice, or so that there's a team approach in that too?
Absolutely. That's why I love working with like-minded professionals who also practice TEAM. And I also teach a training course on how to do better team therapy with children and adolescents. And so a lot of those therapists are at our center too. So it's really helpful. You're absolutely right. You're picking up that it could be a lot of work and a lot of balls to juggle between child session, parent session, child parent sessions. So if someone else is able to do one of those elements, I find that it is very easy. I think I'm open to doing both if everyone is on board, right? Mm-hmm. Like just like in couples therapy, if both people are working with individual therapists before they come together, if they're going at different paces, it could be hard to do that, right? So if the child is going more slowly than the parent, sometimes it's helpful for someone else to see the parent to help them cope with their frustration, or, how to do more of the work at home. So I think it's hard to say each case, but in general, you're absolutely right. It is a lot to juggle and orchestrate.
I have two questions for you. One, you just mentioned your teaching for therapists, online teaching. I've heard people sing your praises for your fantastic teaching. Of course, you've proven that today with your fantastic teaching. But suppose I'm a therapist in New Jersey or Oklahoma or Ghana or wherever, and I'm saying, boy, this Taylor, she's really got her stuff together. And I'd love to learn from this woman how to work with children using team therapy. How would they attend one of your, I think maybe they're 12-week introductory classes, online classes, or tell us what kind of offerings you have there for therapists who might want to be learning more from you?
Sure. We have and starting in the fall will be the next time the 12-week group runs. So Thursday mornings, New York time. There's information on the website, feelinggoodinstitute.com, but there's a 2-hour course taught by myself and Erica Hulse Thursday morning, starting in the fall. And that's a 12-week structured curriculum. We go through each of the elements of TEAM and how to adapt it to work more effectively with children and adolescents. And then it's ideal for those that have taken that course to then move on. I have a monthly consultation group that I run, again, myself and Erica, on how to use TEAM with children and adolescents. And that is a little bit less structured in that we'll teach on a topic for the first hour and 10 minutes, and then we'll do case consultation to help therapists that are stuck with a case, and then do some Q&A at the end.
Are these classes fun?
They are fun. I love them. They're the highlight of my week in the fall and month. So we always attract a great group from all over the country, all over the world. We've had some people from Australia, India, Israel. It's always fun for me to keep up with the different time zones, right? I know when we started this podcast, I think, Rhonda, it was dark in your background and light out, right? So similarly, we've had people all over the world at different time zones. So it's so fun and engaging. And the 12-week course that I teach in the fall has a didactic component and then small group practice as well. So you'll always have a chance to practice and give and get feedback on each element of TEAM.
Mm. And again, to get information, you said the Feeling Good Institute of New York.com, or what did you say?
So we just redid our website. It looks great. It's all integrated now, but listeners can go to either feelinggoodinstitute.com or feelinggoodnyc.com, and it'll route you to the same website.
Feeling Good NYC.
Yep.
Feeling NYC.com. Thank you. And then the second question I have is, have you ever considered doing similar training courses for general citizens, for parents, say, for example?
It's something I have been wanting to do, and I'd love to, if listeners have an interest, I'm definitely open to doing groups. The challenging thing always ends up becoming with licensing and if we're doing therapy or not. But if there is an interest, I will definitely think of ways, just kind of information sessions or something like that.
So you'd contact Taylor at Feeling Good, that's one word with 2 G's in the middle, nyc.com, and then they could find you.
So that would be Taylor at feelinggoodinstitute.com.
Oh, that's the email, Taylor. At feeling, that's the second thing, at Feeling Good Institute.com. And would that be the same as the Feeling Good Institute in Mountain View, California?
Yes, exactly.
And so you're affiliated with them, but then they could make contact with your group in New York, or they could go to feelinggoodnyc.com to get your website.
Yep. It's all together. We're all joint.
Okay. Great.
Taylor, this has been such a great podcast. I'm so happy that you contacted us. It's been so interesting. And it's kind of a long podcast for what we normally do, but I wonder if it would be appropriate if you could walk us through like a case example to show us, the beauty and the excitement of what you've done.
Absolutely. I'd be happy to do that. One, I may make it too long, so you're welcome to cut me off. But whenever I teach on this topic, I want to make sure one of the favorite analogies that people have that really help kind of get parents and kids to think about OCD and how to approach it. I'll say it really quickly if that's okay. And then I'll get into a case is what I call the popcorn analogy of how to really handle OCD. And so maybe, Rhonda, you could be my patient as I walk you through the example. It would be helpful.
Okay.
Rather than telling people what I do, I would love to do it with you. So I'll say, Rhonda, have you ever made popcorn?
Yes.
Yeah. How do you make popcorn?
I just put the envelope that comes with in a box. I take it out of the box and then I put it in the microwave. I turn it on and I push the buttons and then it pops.
Okay, so you're saying you take the bag of popcorn with all the little kernels in it, probably like hundreds of kernels, you heat it up, and then you get a yummy bag of popcorn, right?
Yes.
And then you start eating the popcorn?
Yes, that's exactly right.
Yep. And what do you do do any of them ever not pop? Or when you do it, do you have a magic twist and they all come out yummy?
No, quite a few don't pop, sadly.
So what do you do with those burnt kernels?
I just throw those away.
So you don't look at them, you don't think about them, you don't wonder why they're burnt, you just toss them aside?
No, I do all that. I wonder why they didn't pop. I wonder what I could do next time better so that I could make them all pop. And
yeah, you do? That sounds very time consuming.
Well, it doesn't take that much time. While I'm eating, I'm thinking, how could I have done this better?
Oh, interesting. Well, that's an anomaly. I would say most people just kind of toss those burnt kernels aside, right? And how did those get burnt? Did you ever come up with an answer or a solution to that? Why did those get burnt?
No, I never have.
All the popcorn starts out the same and some end up burnt and we just toss them aside and most of them end up yummy and delicious, right? And so our brain is just like a popcorn machine. It starts out with all these wonderful things and for some reason, some of the thoughts come out burnt. And those are your OCD thoughts, right? We have OCD because we have a brain and those thoughts just end up burnt. But normally, most people just toss them aside. They don't look at the burnt kernels. They don't wonder why they're burnt. They just toss them aside and continue to enjoy the yummy, delicious popcorn. And so when I'm helping patients to overcome their OCD, I want them to work on just tossing aside those burnt thoughts, not thinking about them, not learning about them, and knowing that they just have them because they have a brain.
That was awesome.
So a lot of patients really like that analogy, and therapists, it helps kind of break down that there is no reason that they come out burnt. Obviously we've talked about some reasons that they come out burnt before, but in general, if we could kind of just get to the place of tossing them aside and continuing to enjoy all the other yummy, delicious things, that's how we can really overcome our OCD.
I love that. Thank you.
Sure. My pleasure.
So can you tell us about a client that you worked with and how you successfully treated them?
Sure. There's so many wonderful cases that come to mind. I didn't prepare, to be honest, a specific case, but I'll take a minute and think of my last teen that I treated for OCD. He was a wonderful teen who was an amazing baseball player. And he was, at the beginning of the pandemic, really gearing up for the college recruitment process. It was such a challenging time for so many teens whose dreams kind of got put on hold. And I was actually treating him for sleep issues. That was the reason for referral. As I said originally, most people don't come to me and say, my child has OCD. Can you treat them? They'll have trouble getting their homework done, trouble sleeping, trouble with performance, trouble with friends, won't go on sleepovers, the vast majority of things. And so in talking to him, we uncovered, I had done, I believe, the YBOC, which is an assessment for OCD symptoms, frequency, and intensity, right? And we discovered lots of different rituals that he had. He wasn't performing well at baseball and he wasn't sleeping. And it turns out that he feared throwing up. He once threw up. And so he went through this intricate ritual to make sure his whole bed was set up in case he threw up at night. And then wouldn't eat dinner at night to make sure that he had nothing in his stomach to throw up at night. Some of the obsessions were kind of checking that the door was open a certain amount so that he could quickly get out of his room. He was at one point sleeping in the bathroom, right? So these were all just to kind of make sure that he would be okay if he threw up at night. And so a large part of that treatment, right, was figuring out what are the symptoms that he's having. And this was actually a case where it didn't involve the parents at all, because it was happening at night and the parents didn't even know it was happening. So we created a hierarchy of exposures that he would have. And this was actually a case that was virtual during the pandemic. So we weren't doing the exposure in the office, but I was, walking him through it at night. And so it involved first not sleeping in the bathroom, and it was very difficult for him to go to sleep. He would keep a rag by the side of his bed. He would keep water by the side of his bed, right? So it was all of those things that tried to help him feel like it would avoid him throwing up at night. And so some of the symptoms that he was also scared of experiencing were nausea, dizziness, all that are part of nausea. So some of the exposures we did do were like spinning in his chair, learning to tolerate nausea without drinking water, without having a rag present, without having a direct access to the bathroom. He would avoid eating before going to bed. So we would have him eat and then spin in a chair, right? So to help him tolerate and get more comfortable with all of those things that he was trying to avoid. I will say in this particular case, we did do all the exposures, but 70% probably, and that's what I see often with children, 70% of the success of the treatment came from psychoeducation, came from the value chart that we did, where we let him see what values that showed about him, that he cared about his performance, that he wanted to be a good son. I'm happy to go in more depth with anything. I know we're a little bit short on time, right? And so going over the popcorn analogy and kind of letting him know what was going on, what was fueling, what was going on in his body, kind of the false alarm system that we talked about before with fight or flight. So letting him know what was going on really empowered him to better tolerate the discomfort that he experienced when doing the exposure. And the end result was he was finally able to sleep in his bed after eating dinner and have his door shut. And he was able to get a restful sleep as opposed to sleeping in the bathroom and fearing throwing up.
How long did the treatment take?
Really quick, probably I think that was 6 sessions.
Fantastic. Well, thank you so much, Taylor. It's always a joy to see you. And
I'd love to see you both.
Please give our love to Gregg and to your wonderful children, and to your colleagues, who I think for the most part I don't know. But how many do you have working with you there?
I think there's about 8 at this point, other
Cool.
therapists in the New York clinic. It's exciting to see us grow and connect with such wonderful therapists and people who love learning your methods and have seen so much success with it.
That's cool. Any final parting comments, Rhonda?
I just think this was so exciting, Taylor. I love how specific you got. That was a really brilliant example of treatment. I loved everything you talked about, and it was a great learning. And I'm sure this will be really positively received, and we're going to get lots of great comments. So thank you so much. It was wonderful.
My pleasure. And thanks to all our listeners as well, and for you both for putting this on. I loved coming on and talking with you.
Yeah, until next time, have a good one.
Yeah, thank you.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.